Good morning. My name is Bill Schnettler, and I have the great honor of presenting the topic Ehlers-Danlos in pregnancy today. I'm a maternal fetal medicine physician here at TriHealth and the director of the TriHealth Center for Maternal Cardiac and Critical Care. I've been at TriHealth for 7.5 years, and over that time, I've had the great privilege of working with many women who either present to pregnancy with the diagnosis of Ehlers-Danlos, or who present to pregnancy with features characteristic of Ehlers-Danlos, where we are making the diagnosis for the first time. Today we're going to discuss how Ehlers-Danlos impacts pregnancy and how pregnancy in turn impacts the course of Ehlers-Danlos. We'll begin with a discussion regarding the clinical implications of Ehlers-Danlos overall and the various types that have been delineated by national societies. We'll have a brief discussion about the pregnancy-related physiologic adaptations that must be considered when treating and caring for a woman with Ehlers-Danlos syndrome. We'll then move to a discussion regarding the impact that pregnancy has upon this disease. In reverse, we'll discuss the impact that Ehlers-Danlos has upon pregnancy and pregnancy outcomes, specifically the maternal and the fetal outcomes. And finally, we will lay out a management algorithm for women with Ehlers-Danlos based on their type. So let's begin with the discussion regarding the pathophysiology of Ehlers-Danlos. As this audience knows well, Ehlers-Danlos is an inherited condition where genetic alterations affect the synthesis and the processing of various tissue types and cellular types throughout the body. Most notably, collagen and extracellular matrix proteins such as glycosaminoglycans are deeply affected by these genetic alterations. Now, there are 13 different types of Ehlers-Danlos characterized by their phenotypic manifestations, their inheritance modes, and the biochemical abnormalities that are characterized and delineated by the genetic alterations. The most common types of EDS, or Ehlers-Danlos syndrome, are the classical types, which includes types 1 and 2, hypermobility type, which is type 3, and vascular type, which is type 4. All three of these most common types of EDS are inherited in an autosomal dominant fashion. Now, the characteristics for each of these types do tend to overlap, but are most notable for the classical types being skin hyperextensibility, wide atrophic scars, and joint hypermobility. The classical types 1 and 2 are caused by genetic mutations in the ProA1 and ProA2 genes, which control for the collagen type 5 chains. The hypermobility type is characterized by generalized joint hypermobility, which we'll discuss a scoring system for how to diagnose this. The genetic mutations involved include the TNXB and COL5A1 or 5A2 genes. Finally, the vascular type is characterized most predominantly by the concerns regarding arterial or organ rupture. And the gene causative for the vascular EDS type 4 is the COL3A1 gene. Now, EDS is prevalent within our population, affecting roughly 1 in 2,500 to 1 in 5,000 individuals. It can affect males, females, and all racial and ethnic groups. EDS hypermobility type, or type 3, is by far the most common. And what's interesting, as I alluded to in the introduction, is that there is an increased rate of diagnosis among women presenting for pregnancy care. And that is due to the fact that such women have an increased healthcare utilization during their pregnancy. they seek care more often. And so the healthcare system on the whole has a greater impact and a greater influence on shaping that woman's health picture during that period. Now, there are also various physiologic alterations associated with pregnancy that may unmask predominant features, and we're going to discuss those in great detail. As discussed on the previous slide, the major features of Ehlers-Danlos overlap between types. These major features involve the skin, predominantly hyperextensible skin, tissue fragility, increased bruising, atrophic scarring, and thin or translucent character to the skin. Often the skin is described as velvety. Regarding the joints, there's a generalized hypermobility in all joints, but often women will have a history of experiencing dislocations or subluxations in their past that may then clue the clinician in to the potential for an EDS diagnosis. Regarding the musculoskeletal system, infants may often have been diagnosed as hypotonic. Children that may have been diagnosed with flat feet or pes planus. Individuals who have pectus excavatum or a high arched palate may be suspected as having an EDS type. And finally, one of the most difficult issues that we face in medicine is the issue of chronic pain. And often women that I see that carry the diagnosis of EDS or are newly diagnosed with Ehlers-Danlos will have been labeled as chronic pain patients for long periods of time, specifically chronic pelvic pain. Often these women will have been treated with a myriad of therapies, and perhaps a resistance to local anesthesia has been documented or noted during the pregnancy. I believe it's helpful for us to review some clinical features of patients with Ehlers-Danlos so that the astute clinician may quickly perform some physical exam tests during an office encounter to help quantify and score a patient's hypermobility and help potentially lead to a new diagnosis of EDS. The Baden Hypermobility Scale has a max score of 9 and requires a score of 5 for diagnosis. Now, the first characteristic is passive dorsiflexion of the fifth digit, the fifth finger, beyond 90 degrees with the forearm flat. And this image depicts what this characteristic would look like on examination. Now, an individual is scored 1 point for each arm and each fifth digit, whether it can be extended beyond 90 degrees. The second characteristic is passive apposition of the thumb to the flexor aspect of the forearm, and the image depicts this, the second image down. And again, 1 point is awarded for each side, each thumb, right and left, whether it can be extended to the point or flexed to the point where it can touch the forearm passively. The third characteristic is hyperextension of the elbow more than 10 degrees, and again, 1 point for each side that can do this, as depicted in the image above. The fourth characteristic is hyperextension of the knees beyond 10 degrees, 1 point being awarded for each knee. And finally, flexion of the waist to allow for the individual to place his or her palms on the floor. This awards 1 point, such that if an individual carries all of these characteristics bilaterally and can bend at the waist to allow the palms to rest on the floor, that represents a max score of 9. Additional characteristics to evaluate during the physical exam include an assessment of the individual's skin. Skin hyperextensibility is defined as the capacity to stretch the skin 4 centimeters or more at a neutral site, such as the ventral aspect of the forearm. And in this image, one can see a marked skin hyperextensibility. An evaluation of any surgical scars or scars from prior injury is also important among these patients, in that if a scar appears wide atrophic, thin, translucent, or poorly healed, that is also a clue that this individual may have an EDS type. Finally, additional features to elicit during the evaluation include any history of hernias or wound dehiscence, skeletal abnormalities such as scoliosis, autonomic instability such as POTS syndrome or syncope, headaches including all types such as migraine and tension types, delayed gastric emptying and irritable bowel syndromes, increased bruising with minor traumas, and most notably for this discussion, a gynecologic and obstetric history that elicits any evidence for cervical insufficiency, such as preterm birth or mid-trimester deliveries, uterine prolapse, and any organ rupture, such as uterine rupture or rupture of the bowel. So let's transition to a discussion regarding pregnancy physiologic adaptations. For this discussion, we'll focus on the cardiovascular adaptations that are the hallmark of pregnancy. Specifically, the cardiovascular system faces a tremendous increase in cardiac output. This cardiac output is designed to help nourish and provide oxygen-rich blood flow to the growing fetus. The cardiac output increase is most notably attributed to an increase in blood volume and to some degree an increase in heart rate and cardiac output via a increased stroke volume. Now, the increased stroke volume comes from a total body water increase. And as a result of that, even though the red cell mass increases, the blood concentration or the concentration of red blood cells is actually diminished. And as such, we have this physiologic anemia of pregnancy, where the total body water and the serum has increased, but the red cell mass hasn't increased to the same capacity. Not only is cardiovascular and cardiac output increased during pregnancy, but there's also a redistribution of blood flow throughout the body. In the non-pregnant state, the non-pregnant uterus typically receives 2 to 3% of the total cardiac output. However, at term, the gravid uterus receives up to 20% of cardiac output. And this is again to help nourish and provide good oxygen-rich blood flow to the growing fetus. The pulmonary, hematologic, immunologic, and gastrointestinal systems also experience a tremendous amount of physiologic adaptation. And again, these are all adaptations to help protect and nourish the growing fetus. The pulmonary system is marked with an increased tidal volume, again to increase the amount of oxygen coming into the maternal system in circulation to help provide good oxygen nourishment to the fetus. But as the uterus grows and the chest cavity becomes somewhat restricted with a diminished amount of diaphragmatic excursion, the functional residual capacity drops by roughly 20%. This equates to a diminished reserve for the female, such that if she develops an acute respiratory failure, there is a much more rapid and marked decline in pulmonary function. The hematologic system is noted to experience an increase in the liver's production of coagulation factors. And this is nature's way of protecting the pregnant woman from dying after the placenta separates following delivery. So the increase in hypercoagulability of pregnancy is both a benefit to the gravid woman, but also can create additional problems that we'll discuss moving forward. The immunologic system changes in that cell-mediated immunity is diminished, and this is designed so that the pregnant woman does not reject the fetus, given that The early blastocyst and the implantation of the blastocyst into the uterus are cells of which 50% of the DNA is not recognizable by the maternal immunologic system. The cell-mediated immunity must change and become more tolerant to allow for invasion of this blastocyst with technically foreign DNA into the maternal system and allow that blastocyst and that placenta to invade and set up good blood supply and good anchor into the maternal tissues. Finally, due to the hormonal effects of pregnancy, the gastrointestinal system experiences a greater degree of smooth muscle relaxation. Now, this is designed to really allow for the uterus to remain relaxed because the uterus is made of smooth muscle. But the GI system is greatly impacted by these hormones as well. And so the gastrointestinal motility is diminished due to the smooth muscle relaxation effects, most notably from progesterone. So again, as I alluded to previously, the goals of these physiologic adaptations are to help the mother and help the fetus grow by optimizing fetal growth, protecting the mother from delivery complications such as hemorrhage, and to help achieve successful pregnancy outcomes. We discussed briefly the cardiovascular system physiologic adaptations, and notably the cardiac output increase. Now, if we remember that cardiac output is a product of heart rate times stroke volume, and we look more closely at what leads to the 30 to 50% increase in cardiac output, we can identify that in pregnancy, a woman's heart rate increases by roughly 20 to 25%. But as noted before, blood volume increases by roughly 50%. In addition, the hormonal effects of progesterone and relaxin allow for a diminishment or reduction in peripheral vascular resistance. The combination of this reduction in peripheral vascular resistance and increase in blood volume relate to an increase in stroke volume. So not only does heart rate increase, but also stroke volume increases, and the combination of these two leads to the 30 to 50% increase in cardiac output. I've mentioned the hormonal changes, and most notably progesterone and relaxin, throughout this discussion. Now, progesterone relaxes vascular, gastrointestinal, and genitourinary smooth muscles. Its goal is to reduce uterine activity and prevent premature delivery. It also blunts maternal vascular responsiveness. So, in patients with Ehlers-Danlos, as we will discuss, oftentimes there is a predisposition for postural orthostatic tachycardia, and progesterone can serve to blunt the natural homeostatic responsiveness of the vascular system and create a worsening of a woman's POTS syndrome symptoms. Now, relaxin is also charged with helping to allow the uterus to stretch and to expand and allow for the growing fetus to distend that uterus throughout pregnancy. Relaxin also helps maintain cervical integrity and prevent premature cervical dilation throughout pregnancy. Now, unfortunately, the hormonal effects, as mentioned previously, can then impact Ehlers-Danlos through increased propensity for joint instability, increased autonomic instability, delayed gastric emptying, and potentially vascular complications, as well as headaches. Begin with a discussion regarding joint instability, which is a common issue affecting at least a quarter of women with Ehlers-Danlos syndrome. Now, the joints, and I say joints with quotations because in non-pregnant individuals, These joints, namely the sacroiliac joints and the pubic symphysis joint, don't really serve as joints. They remain relatively fixed within our pelvis. However, due to the relaxing effect of progesterone and relaxin, these joints do become more mobile and can often cause sharp-shooting pains as the fetal head engages and presses down on the pelvis. Additionally, as the growing uterus and growing fetus progress throughout pregnancy, it tends to bring the woman's center of gravity more forward and can develop the propensity to have falls or a loss of balance, and a tremendous amount of kyphosis of the individual's spine to try to pull her center of gravity back over her grounded center where her feet are. Regarding autonomic instability, pregnancy can have a dramatic effect, as mentioned before, on a woman who presents with a diagnosis of EDS and may have already carried the diagnosis of autonomic instability. Pregnancy may make that experience worse. Now, in normal pregnancy, roughly 5% of women will experience a full syncopal episode. 30% of women will experience at least one pre-syncopal episode of feeling faint or lightheaded, maybe having the development of nausea, vomiting, tunnel vision. And 10% of women will experience recurrent pre-syncopal episodes. Now, the causes of these episodes relate from any disruption in blood flow and cerebral perfusion to the brain. How this works is that a paradoxical reflex arc exists when the venous system experiences venous pooling. Venous pooling, predominantly in the bilateral lower extremities, leads to a drop in cardiac output, namely via a drop in preload. Now, our arterial baroreceptors sense the drop in cardiac output and the drop in blood pressure, and they send a catecholaminergic surge, which triggers the heart rate to contract vigorously. However, if the preload is dropped such that the intracardiac chambers are volume depleted, mechanoreceptors sense the volume depleted chambers through C fibers, and this stimulates the dorsal vagal nucleus in the medulla, as depicted in the image on the right, which then triggers through the vagus nerve a bradycardic response. When the blood pressure is already low and the bradycardic response kicks in, this can cause an individual to experience presyncope or syncope. In women who are predisposed to this process at baseline, the effects of venous pooling from progesterone that has, again, relaxed the vasculature predominantly throughout the body, but in the lower half of the body, that will tend to cause more venous pooling and can trigger this paradoxical reflex arc and cause full-on syncope. Headaches are a difficult topic in all facets of medicine because they're difficult to treat and difficult to diagnose often. Unfortunately, headaches are common in pregnancy. 50% of women who experience headaches in pregnancy will describe them as very migraine-like. The other 50% of headaches are a mix of tension or cluster or other types of headaches. Now, in general, the occurrence of migraine headaches are modulated by estrogen fluctuations. And so, with the increase of estrogen in pregnancy, 60 to 70% of women who experience migraines prior to pregnancy will have improvement with pregnancy, namely because the estrogen isn't fluctuating, it's just remaining high. Around a third of women who have migraines prior to pregnancy will experience no change in their symptoms, And unfortunately, 5% of women will have a worsening of their migraine headaches. Now, women who have EDS and have headaches at baseline may potentially be more likely to fall into that 5% category of a worsening of their headaches during pregnancy. Most notably, those that experience a worsening experience it during the postpartum period, when the recurrence likelihood is greatest. Breastfeeding can mitigate that recurrence because it relates to a stability of hormones to help provide appropriate milk letdown and good milk supply for the newborn. And so breastfeeding is highly encouraged in women who experience headaches during pregnancy, and specifically those with EDS and headaches, to help stabilize the hormonal fluctuations and reduce the recurrence of severe migraine headaches. Delayed gastric emptying, as noted before, is also an effect, namely from progesterone on the GI tract. Progesterone inhibits gastric smooth muscles, which relates in a decreased colonic smooth muscle contractility, prolonged gastric emptying, and delayed colonic transit. But there are also other hormones, such as relaxin, which can inhibit GI smooth muscle, and other factors of pregnancy that can cause a delayed gastric emptying. Dietary factors, including a lack of fiber, iron supplementation, the nausea and vomiting of pregnancy, a propensity towards dehydration or diminishment in water intake, especially when women are experiencing nausea and vomiting early in pregnancy. A reduced level of physical activity that's noted in pregnancy can delay gastric emptying. And various mechanical factors, such as the physical impedance due to uterine growth and the compression of the growing uterus upon the GI system. Now let's transition to the impact that Ehlers-Danlos has on pregnancy and pregnancy outcomes. We'll begin with a discussion on infertility and early pregnancy loss, and then touch on the topics of cervical insufficiency, preterm birth and premature rupture of the membranes, placenta previa and abruption, fetal growth disturbances, delivery and delivery complications, and finally maternal mortality. Infertility is common among women with Ehlers-Danlos syndromes of all three of the most common types. In this study published in Obstetrics and Gynecology from 2014, rates of spontaneous abortion were higher than the background population rate across the board for the three most common types of EDS. Most notably, the hypermobility type had the highest rate in comparison to the background population rate of 43%. And this percentage equates to women having experienced any miscarriage or spontaneous abortion. The per pregnancy rate of spontaneous abortion or miscarriage is roughly 20%, such that 1 in 5 clinically recognized pregnancies will end in a miscarriage. However, 43% of women having ever been pregnant have had at least one miscarriage or spontaneous abortion. 58.2% of hypermobility EDS patients have experienced any episode of spontaneous abortion. Ectopic pregnancy is also increased across all three types. The background rate being 2% of all women have experienced an ectopic pregnancy, while 7.7% of women with vascular type 4 EDS have experienced an ectopic pregnancy, and 5% of all women with any of the three major types have experienced an ectopic pregnancy. And finally, roughly 10% of women in the background population struggle with infertility. However, Ehlers-Danlos types across the board are much more wrought with increased rates of infertility, with a 44% rate of infertility among all three groups combined. When we look at those infertility causes, The common causes that affect the background population are certainly present and common among women with Ehlers-Danlos: PCOS, endometriosis. However, those two seem to be pretty similar to the background rates. What's interesting is those that were told not to conceive due to their diagnosis of Ehlers-Danlos. Roughly a quarter of women with EDS had been told over their lifetime to not attempt conception. And this is part of the discussion that I think we are tackling today, in that it's important to identify the risks associated with EDS and the various complications and ailments that can impact the woman and her pregnancy, but that there are methods to treat and achieve successful pregnancy outcomes. Cervical insufficiency is one of my specialties, and it's something that we're all taught in medical school and in residency that EDS has an association with. And cervical insufficiency simply means the asymptomatic, kind of silent cervical dilation that occurs in the second trimester that allows the pregnancy to be expelled and delivered without much pain or uterine contractions. Now, there are numerous case reports and case series suggesting an increased rate of cervical insufficiency among women with Ehlers-Danlos. However, there are not a tremendous number of true scientific publications that delineate the overall incidence and risks that a woman with EDS presents for cervical insufficiency. In this study that came out this year, the odds ratio for any woman with any type of EDS for development of cervical insufficiency is 3.11, so threefold higher odds of having cervical insufficiency than the background population. Now, when we think about treatments for cervical insufficiency, there's also the concern that tissue fragility and increased tissue trauma among people with Ehlers-Danlos syndrome make placement of a cervical cerclage, a surgical procedure, more higher risk. And we'll get into that as we discuss management. Preterm birth and premature rupture of the membranes is something that has a fair body of evidence to support its association with Ehlers-Danlos. In the U.S. Healthcare Cost and Utilization Inpatient Database from 1999 to 2014, the odds ratio for a woman with any type of Ehlers-Danlos to experience preterm birth, which is delivery under 37 weeks gestation, is approximately 47 to 50% higher than the background rate. Now, what's interesting is that that's assuming the mother has Ehlers-Danlos. But as I discussed, Ehlers-Danlos is often inherited in an autosomal dominant fashion. And so there's a 50% chance that the fetus is impacted by EDS as well. And what's interesting to note is that when the fetus is affected as well as the mother, the risk for preterm birth is more than double the background rate. The background rate for preterm birth in our country is roughly 12%. The rate for when the mother and fetus are impacted by Ehlers-Danlos is 39.5, which is actually 3 times the background rate. The rate for PPROM, or premature preterm rupture of the membranes, is nearly 50%. When we think about why preterm delivery and specifically premature preterm rupture of the membranes may occur, I find it helpful for us to look at the extracellular matrix composition of the amnion, which is, in layman's terms, the bag of water, and the chorion, which is the placental/bag of water interface, or the outer lining of the bag of water where the bag of water is attached to the maternal uterine lining, or the endometrium/decidua. And when we see and look at the basement membrane of the amnion, we can see that there's a myriad of collagen types and various extracellular matrix components. And if one has a disorder of collagen synthesis or collagen integrity, one could see that that amnion may in fact have a higher propensity toward tearing and rupture. Additionally, when we look at the chorion, or the interface between the bag of water and the maternal lining, there is also a myriad of collagen types and proteoglycans. And if there's a deficiency or dysfunction in any of these collagen types, one could see that there could be a diminishment in the ability for the amnion and chorion to adhere well, and a propensity towards disruption of that interface, leading to the potential for placental abruption or membrane rupture. So when we look to the data to see if there is an association between Ehlers-Danlos and placenta abruption and abnormal placental location, we can see from that same U.S. healthcare cost and utilization inpatient database that there is a higher propensity for both, that the odds ratio for placenta previa is over 2 times greater than the background rate, and that the odds ratio for placental abruption is roughly 70% greater than the background rate. And again, this is owing to those potential collagen deficits. If there's a disruption between the amnion and the chorion, the adherence of those two together is going to be disrupted, and potentially the ability for the placenta to migrate toward the area of best blood supply, which is near the uterine corpus and fundus, up near the top, is altered. One of my favorite terms in medicine is trophotropism. And what trophotropism relates to is the same principle as phototropism that plants undergo. Plants will preferentially grow and turn towards the sun to allow for the best collection of UV light and energy sources. Well, the placenta does the same thing. The placenta will preferentially grow toward the area of the uterus that provides the best blood supply. And if there's a disruption or a problem with cell signaling at the layer of the amnion and the chorion, then that trophotropism is inhibited and placenta previa is likely to persist. Now, along those same lines, if the placenta's ability to grow preferentially toward improved blood supply and nourishment, and if that is altered, well, then the downstream effect is a potential growth restriction or a disturbance in the fetal growth and a disturbance in the placental growth. A Dutch cohort study from nearly 20 years ago looked at women with an underlying diagnosis of Ehlers-Danlos, and then those women who also had fetuses impacted by Ehlers-Danlos, and found that in mothers with EDS, the rates of fetal growth restriction were nearly 22%. Now, we use as a background rate of fetal growth restriction 10% among the background population. And so women with EDS had a near doubling of the rates of fetal growth restriction. And that's pretty consistent with the U.S. Healthcare Cost and Utilization Inpatient Database report from this year that found an 80% increase in fetal growth restriction with its odds ratio. When we discuss delivery mode and the complications of delivery, we can see that across the board, women with a diagnosis of EDS have increased rates of complications in many of the expected complications. For instance, hemorrhage. Background rate of postpartum hemorrhage or any type of hemorrhage is roughly 3 to 5% in our country. Among women with EDS, it's 18.8%, and among women with EDS who have fetal effects, it's 7.5%, so closer to the background rate. Complicated healing of episiotomy, women with EDS have a near doubling of their complications from episiotomy and a doubling of their third-degree perineal tears. If we specifically look at women who have vascular EDS or type 4 Ehlers-Danlos syndrome, This is a nice study from Genetics and Medicine from 2014, looking at pregnancy outcomes of 113 pregnancies from 38 women with vascular EDS. And we can see here that these women underwent either a vaginal delivery, an emergent cesarean delivery, or a cesarean delivery, and that they experienced, especially among those with undergoing emergent cesarean, a 5% rate of vascular complications, a near 3% rate of cesarean complications, 3% rates of PPROM and preterm birth, and 2% rate of abruption. Now, those undergoing cesarean delivery that wasn't emergent experienced a roughly 5% rate of hemorrhage and a 5% rate of placenta previa. So complications definitively increased among women with vascular Ehlers-Danlos. And most importantly, an increased risk for maternal mortality. Now, this is looking at women with EDS of all types, and specifically the bottom two references looking at women with vascular EDS. Now, in women with EDS of all types, the rates of maternal mortality are perhaps slightly increased above the background rate. In 2018, the Centers for Disease Control in the United States noted that the maternal mortality rate was 17.4 per 100,000 live births, or roughly as 0.0174% risk of maternal mortality in our country. That sounds very low in comparison to other developed nations across the globe. Our rate is actually higher than many other advanced medicine societies, and our rate has been going up over the last 10 years. Now, among women with vascular Ehlers-Danlos, the rate is certainly much higher. In the Murray study that I discussed earlier, the maternal mortality rate was 5.3%, and in Pepin's landmark paper from 2001 in the New England Journal of Medicine, the rate was 6.6%. And these studies and this data is what have helped shape our approach to the preconception counseling of a woman with vascular EDS to strongly consider the risks inherent to pregnancy. So that allows us a good segue into a discussion regarding the management of women with Ehlers-Danlos syndrome who are choosing to become pregnant or who are pregnant. Now, as a maternal fetal medicine specialist, I love the opportunity to provide preconception counseling because this allows an hour-long sit down with the patient to review any sort of genetic tests that she may have undergone, or to discuss available options for genetic testing, to review a full pedigree analysis, and to review any screening studies that may have been performed or should be performed prior to pursuing pregnancy. Women with classical types of EDS, types 1 and 2, often present having already had the diagnosis and may have already undergone genetic testing for their EDS type. In these women, I discuss dietary changes, including copious hydration and potentially an increase in salt intake to help mitigate any sort of autonomic instability or drop in preload that could then trigger that reflex arc, resulting in bradycardia and syncope. I also discuss the option of vitamin C supplementation to help maximize the strength and quality of collagen cross-linking. If a person presents with a history of autonomic instability or experiences it throughout pregnancy, we may consider midodrine, alpha agonist, or Florinef, which is a corticosteroid that helps, mineralocorticoid that helps allow for maintaining the total body water and specifically the intravascular volume. Magnesium oxide may be a good option for women who present with headaches as a preventative and one that is completely safe in pregnancy. For the pelvic joint pain and instability, potentials for falls that we discussed, pregnancy support belts with shoulder straps can be very helpful to lift the growing gravid uterus off of the pelvic floor and realign the patient's center of gravity over her feet. Additionally, pelvic physical therapy may help with pelvic pain and help provide increased support to the pelvic floor to help prevent prolapse or severe vaginal lacerations during delivery. Preterm birth prevention is a necessity in all of these women, and I recommend serial cervical length screening beginning at 16 weeks and extending through 24 weeks with transvaginal ultrasound. Should we find evidence that the cervix is starting to open up or demonstrate funneling, we can provide therapies including pessaries, progesterone supplementation, and potentially even have a discussion about cervical cerclage or surgical options. From a maternal surveillance standpoint, I believe that a baseline echocardiogram should have been performed prior to pregnancy, or if not, in the first trimester, to ensure that there's no aortopathy or any other abnormalities with mitral valve, etc. If any abnormality had been previously documented or identified in the first trimester, I repeat that echocardiogram at roughly 30 weeks of gestation, because this is when the maternal cardiac output is peaking and going to plateau. So I want to know, how has this woman's heart been able to tolerate that peak cardiac output to be able to prognosticate how she will do throughout the remainder of pregnancy and delivery. From the fetal standpoint, due to the increased risk for fetal growth disturbance, I recommend a detailed obstetric ultrasound at 20 weeks, followed by serial growth ultrasounds at 32 and 36 weeks to ensure that the fetal growth is maintained. Because we're fortunate for our own Ehlers-Danlos program here at TriHealth and our Center for Maternal Cardiac and Critical Care, where we provide multidisciplinary input for patients, I would recommend consultations in both of those programs for pregnant women with an underlying diagnosis or suspicion for Ehlers-Danlos. Delivery timing is somewhat controversial, but I feel that in a woman with a classical type of Ehlers-Danlos with normal findings on the surveillance outlined above, a delivery between 39 and 40 weeks is completely feasible and recommended, with a goal for a normal spontaneous vaginal delivery. I would attempt to avoid operative vaginal delivery and episiotomy at all costs. For hemorrhage prevention, we provide standard care, which is active management of the third stage of labor, which means administration of additional oxytocin, gentle traction on the umbilical cord, and early consideration for antifibrinolytic medications such as tranexamic acid or TXA, and uterotonic medications. There are no contraindications to the standard uterotonics, including misoprostol or methylgornovine or prostaglandins. From a cesarean standpoint, due to the potential for increased rates for wound dehiscence or wound complications, I believe that meticulous surgical technique with delayed absorbable sutures for all layers, including the skin, is the appropriate management strategy. An anesthesia consult could be very helpful, especially for those women who have had a blunted response to local anesthetics. And then following delivery, there should be close, vigilant follow-up within the first week postpartum to ensure that the patient's doing well and not experiencing any complications. In a similar fashion, I believe this same management strategy holds true for women with hypermobility type Ehlers-Danlos, with the same recommendations for hydration, salt intake, medications for autonomic instability, pregnancy support belts, serial cervical length screening, delivery timing, fetal surveillance, consultations, and vigilant surgical technique. Now, the type of EDS that is more challenging, and certainly one that should prompt early consultation through our programs, would be women who present with vascular Ehlers-Danlos. Such women optimally would have the opportunity to come for preconception consultation with our genetics team, maternal fetal medicine team, our Center for Maternal Cardiac Care, and our Ehlers-Danlos program here at TriHealth. Throughout that preconception visit, we would dive into maternal testing, pedigree analysis, and certainly discuss obtaining baseline echocardiography and even screening carotid and aortic Doppler assessments. I would strongly encourage such women to maintain copious hydration and potentially increase salt intake along with vitamin C, but I would also strongly encourage these women to initiate a beta blocker for its cardioprotective and aortic protective benefits. The pregnancy support belts and physical therapy are important along with the cervical length screening, but I would plan to follow these patients with repeat echocardiograms monthly, specifically to evaluate the ascending aorta and ensure that there isn't development of any enlargement or, heaven forbid, any type A dissections in that aorta. From the fetal standpoint, I would discuss with the patient the option for amniocentesis for fetal diagnosis, specifically if the woman has undergone genetic testing for herself, such that her genetic abnormality is previously documented. I'd perform a detailed ultrasound at 20 weeks with follow-up ultrasounds each month thereafter and antenatal testing beginning in the 3rd trimester. Delivery timing is much earlier among these patients due to the risk for uterine rupture or other organ rupture. Such women, I would argue, should be delivered in the late preterm period between 34 and 36 weeks via cesarean delivery. I would argue that cesarean delivery prior to the onset of labor should be entertained in any woman with vascular EDS, but certainly any woman who's had a history of any organ rupture. As a planned approach, I would administer tranexamic acid and antifibrinolytic prior to the onset of that cesarean delivery, and I would have medications adjunctively available, including desmopressin or DDAVP and uterotonics on hand for immediate administration in the setting of hemorrhage. Due to the increased risk for wound dehiscence, I would recommend using non-absorbable retention sutures on the fascia and certainly sutures on the skin that could be delayed absorbable. I would strongly encourage an anesthesia consult early due to this increased hemorrhage risk, possible need for intraoperative echocardiogram via TEE or transesophageal echo, specifically if there was any aortic enlargement noted during pregnancy. And anesthesia could discuss the appropriate anesthetic mode given a potential blunted response to local anesthetics. And certainly in these women, I would advocate for very close follow-up with all of these teams within the first week of pregnancy, because this, as we discussed, presents roughly 5-6% increased rate for maternal mortality. And among various guidelines, including the 2018 ESC guidelines for congenital heart disease in pregnancy, management of vascular EDS represents a very high-risk endeavor, one that should be undertaken in a multidisciplinary approach, and equates to the WHO Class 4 pregnancy recommendations, in which such women are often encouraged not to consider pregnancy. This concludes my discussion of Ehlers-Danlos and pregnancy, and I greatly appreciate your attention. Thank you so much.